Hi everyone, I'm Fatima. I'm a third-year resident, and along with Dr. Khalifat, we both worked on this presentation to basically kind of give an overview on opioid use disorder. So I'll be kind of touching on a lot of different aspects of this. So not a lot of details because each single aspect can take hours, if I wanted to talk about them, but it's Friday, so I wanted you guys to leave early. So in terms of talking about general addiction, there's a quote that says, addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Addiction a lot of the times can be influenced by people's own kind of preconceptions about it. So a lot of the times it might not be, some people might not realize that it's actually a disease, just like any other disease. It affects the person, there's ways to treat it, there's ways to manage it, and it has its own symptoms and so on. A lot of the times it's kind of seen as a choice, but obviously as we've learned more about it, we've kind of come to conceptualize it as its own chronic relapsing disorder. So in terms of what patient population you might be dealing with when it comes to opioids, obviously there's no typical profile that you'll be running into. It can really be anybody. And so that's kind of a picture that shows that, it can be male or female, young or old. It can be any educational background, any race really, and it can affect any socioeconomic group too. And one of the things that I think a lot of people who are I know Dr. Khalifat kind of stresses this a lot, is the way that we use words when it comes to treating people who have addiction. A lot of the times, I think we don't realize that the language we kind of use came from times when people had a lot of stigma related to it. So there's been a few different words that have, I think, been changed now, and we kind of use them differently when it comes to talking about recovery, relapse, and so on. So that's an important part of making sure that, the patient is being welcomed kind of in a non-judgmental and respectful environment, instead of pushing them away when they're already kind of having a lot of shame to begin with. And this is kind of a general example to kind of compare. So hypertension, most people, again, conceptualize it as a disease that can be genetic. There's some decisions that you can make that can affect your likelihood of developing hypertension or managing it as well. And it's kind of similar to addiction when you really look at it. There's a huge genetic component when it comes to addiction, and there are choices that people can still make to be able to manage their condition and make it better or worse. And similar expectations when it comes to drug compliance. So contrary to I think what most people might think, the population doesn't have an increased rate of not being compliant with their medications. It's kind of similar to any other chronic disease. And of course, one of the biggest reasons why it's so important to talk about it, and specifically when it comes to opioids, is you can kind of see the extent of the rise of the drug overdose. This is divided by drug type, so you can see kind of the cocaine and heroin have increased, although they're still kind of lower there. But after the creation of the synthetic opioids, the opioid deaths basically skyrocketed because they combined the prescription opioids along with the synthetic opioids. So you can kind of see how after 2015 almost, there was a huge skyrocket in drug overdose. And so kind of an overview when it comes to talking about addiction, not specific to opioids, but this can be about any addiction. So it can be addiction to substances. There's people that are addicted to gambling, shopping. You can be addicted to truly anything, and that's because the underlying system that kind of affects addiction is a normal system that we all have, like the reward system, and it's affected by dopamine. One second. So it's a natural system that we all have. Every time we kind of receive a positive stimulus, that reward pathway gets kind of reinforced. So you start to want to seek out that stimulus, and it can be, the reverse can also be true when it comes to trying to avoid negative stimuli or negative states. So a lot of the times when it comes to addiction, it's all about learned association and behavior. And every single time that the person kind of ends up using these substances or engaging in that addictive behavior, it reinforces that pathway in the brain, which makes it harder and harder to be able to resist in the future. And dependence in general can be psychological and or physical. So there's a lot of substances, for example, that we say are, you can't be dependent on them because medically speaking, when it comes to the actual substance, it doesn't cause physical symptoms of withdrawal. That's kind of what we associate physical dependence on. But even if that's true, there's still psychological dependence that can be just as debilitating as the physical type. When it comes to opioids specifically, we talk about both. So it has both, a physical and psychological dependence can occur. And so this is kind of a nice summary of what kind of ends up happening in addiction. So you see a lot of cravings, you see, and they kind of mimic like the physical needs, like hunger or thirst. The want is so strong there. You see a compulsive use, you see a loss of control where they feel like they can't really, they don't have a lot of control of their actions when it comes to drug seeking or behavior seeking. And then continuing to engage in risky and hazardous behaviors despite the continuous harm that it's shown to have on their lives. And this is kind of another way to visualize addiction. So this is split into 3 different stages. So there's the binge and intoxication phase, and it's color coded to kind of also show what part of the brain that tends to be a big role in it. And then after that, you can kind of see, so that's the basal ganglia. And that's where I'll talk about it in a little bit, but that's kind of where most of the dopamine receptor is, dopamine is released. After that, you get the withdrawal and the negative affect. So that's kind of related to the extended amygdala there. And then the third stage is the preoccupation and anticipation period, which usually either comes before another binge or it comes, along with recovery and remaining abstinent from the substance. And so, so when it comes to binge and intoxication stage, it mostly involves the basal ganglia because that's where the nucleus accumbens is, and that's where dopamine is basically released. So there's a spelling mistake there, but repeated activation, like I said, leads to compulsive substance seeking, and you can strengthen that link the more times you engage in whatever behavior it might be. And then there becomes an association where opioids are linked with euphoria, happy feelings, and then no opioids is linked with a really awful physical feeling and that depression that comes along with it. So there's a lot of different cues that the patient can kind of notice when it comes to the associations, and that tends to kind of overcome even though they realize that it's causing harm, that association is so strong that it kind of overcomes that. And then when it comes to the withdrawal stage, so like I said, it's the extended amygdala tends to be affected, and if we know kind of anything about the amygdala, it tends to be the fear response in the body or the stress response. So whenever that's activated, you kind of see this and there were studies also that showed that during the withdrawal stage, there's a general increase in stress hormones. So you have that negative effect already with the no opioids, but then you also kind of have this hyper aroused state where they're more sensitive to basically being without the opioids. And so there's a very, very strong drive during this stage for them to alleviate this negative state, and that obviously is kind of what leads to that relapse that can happen. And so in terms of the preoccupation and anticipation stage, so this is kind of what we most often refer to as cravings, the kind of the want or the need that people have for using the substance again. It tends to involve the prefrontal cortex, which is basically controlling our executive functioning when it comes to making rational decisions during the day and being able to decide, this is a better choice, that's not a good choice, and so on. So the prefrontal cortex is already affected during this phase. So you can kind of imagine that again, even though they might understand that this is the wrong decision or this is the right decision, the prefrontal cortex is kind of compromised in a way that allows them, their executive functioning to not be working optimally, basically. And that can kind of, again, lead back to that binge state, and continues the cycle. And not only that, but the way that the opioids affect the dopamine reward system, over time, the body is less sensitive to it. So their reaction to dopamine, even the endogenous normal dopamine that you can get from eating, sleeping, sex, and all of that, it just doesn't give the same effect. So you have these people that are kind of going through the stage and they're trying to maybe acclimate back to their normal lives, but nothing's really giving them joy anymore. And so that kind of adds into all of this when it comes to the executive functioning and kind of making decisions while you're at this stage. And obviously the stage can last for quite a long time. It can be short, it can be long. There's no time limit to it, really. So this is kind of a visualization of kind of what might happen during somebody's cycle of addiction. So for example, the example here uses heroin. So you can see over there's multiple uses where you can see that up and down of feeling euphoric, and then as the heroin kind of makes its way out of the system, you kind of go back to being in your normal state, and so on and so forth. And then, for example, here, she stopped using for quite a long time, and you kind of go back to that anxious dysphoric phase that you have to kind of struggle and kind of fight your way out of. And then it shows, so under there you can see kind of 20 days and then 200 days. So even if somebody might go a year without using that substance, the cues that are already there are very, very strong. So that, for example, if a year ago this person was going through a breakup and their grades were bad during school, and then a year later they find themselves going through another breakup, but everything else is different, that cue is so strong that it will still kind of cause them to think about heroin as the solution to basically the depressed state that they can be going through. Whether they've been thinking about it consciously or not, it's just kind of the natural, what the brain does. So that can kind of lead to increased risk for relapse, and that's kind of when most patients need a lot more support. And so that kind of shows, when it comes to relapse, obviously the use can sometimes increase in frequency and all of that. So when it comes to diagnosing addiction, this is again kind of a general overview of anything that you can kind of become addicted to. So there's 3 different domains that we look at. So the risky use and hazardous use, despite they're missing medications, their families are kind of noticing that they're a lot more withdrawn. They can be personal problems, they can be health problems, and so on. But despite that, they still continue to use or engage in that addictive behavior. The second one is impaired control, so trying to stop but being unsuccessful with it multiple times, having cravings or urges to use, using an excessive amount of the substance, or spending a lot of time basically kind of thinking about it, obtaining it, using it, and then recovering from it. And then the last aspect is the physical dependence. So there are certain medications, for example, that will develop a physical dependence. We kind of know opioids is one of them, benzodiazepines is another one, alcohol can be another, and so on. So physical dependence can also be there. So when it comes to the diagnostic criteria, you basically look at a period of 12 months, and you have to have 11 of the diagnostic criteria, and then you can kind of categorize it further in terms of how severe, severe, mild, moderate it is, based on how many of these symptoms the patient is experiencing. So kind of getting more into talking about treatment for addiction. I'm gonna focus a lot on medications, but I kind of wanted to stress the fact that medications are just one tool that is used to treat addiction, but a lot of the times people need to be involved in multiple different kind of safety nets or support systems for the success to be increased. So a lot of that can look like attending AA or NA meetings, having peer support, helping with making sure that they have stable housing, jobs, and so on. So that stuff is very important and kind of helps it helps kind of improve the rate of success when it comes to treating the addiction. So this is a sad slide, it's short. I don't have much to say except this is kind of me getting into talking about opioids specifically. Opioids have existed for many years. Its form has changed over time and how it's administered, but kind of going back to the start, it was derived from the opium poppy, and it's been used all this time basically for its ability to provide pain relief. And in terms of the table over there, that's different opioid receptors and the different effects that it can cause. So different formulations or different types of opioids can have kind of different affinities for these receptors, and in general we kind of tend to use those when it comes to deciding like which medications can be more appropriate and so on. But in general we tend to talk about the mu receptors when it comes to opioids, because that's where the euphoria comes along. So mu1 is kind of what the drug seeking can be to obtain basically that euphoria, and then from the come down there's the mu2 that can cause respiratory depression and constipation. Sorry, from the mu2, basically that's where the deaths kind of come in when you're overdose on opioids. So identifying opioid intoxication, I think the biggest thing that we kind of always write about is the size of the pupils. So whenever somebody is used opioids, their pupils tend to be small. So that's what you look for whenever you're suspecting somebody of having overdosed on an opioid. And then as well, decreased respiration and bradycardia, and that's kind of what leads to, again, that risk of death that's seen a lot higher in opioids compared to other substances of abuse. You can see hypertension as well, and then again that euphoric feeling that's there. When it comes to withdrawal, so it tends to be kind of the opposite of what you would see if somebody's intoxicated, right? So early stages, the eyes water, you can find them yawning a lot, they can have a runny nose, they might sweat, and there tends to be like this sense of doom that they feel, or sense of extreme anxiety. And as it progresses, you can see more sleep disturbances that can happen. Again, their pupils will be the opposite, they'll be larger. They'll have decreased appetite, they'll be irritable, they can be tremulous. And as it continues to progress later on, you can kind of see that tachycardia, the vital sign changes basically with the tachycardia and the hypertension, diarrhea, nausea and vomiting, and then again that depression and that comes with it, and some muscle pains or weakness can sometimes be noted. So as an example, I kind of put heroin there. So heroin has a half-life of 2 to 3 hours. So the onset of withdrawal would be about 8 to 12 hours after the last use. And these symptoms would tend to peak at about 2 days after the person used heroin. But the duration can be anywhere from 5 to 10 days. And there are, I think, a lot of kind of newer information about the protracted kind of withdrawal period that people can tend to have with any substances, where they still kind of tend to struggle months after they've stopped the substance. So when it comes to treating opioid withdrawal, we mostly treat it symptomatically. So we use clonidine a lot for hypertension. You can use hydroxyzine for anxiety. Even benzodiazepines can sometimes be used if the anxiety is really high. You can use NSAIDs for muscle aches and so on, and then whatever antiemetic is available for the nausea and vomiting. And you can kind of just help them through that withdrawal. And there's scales, of course, to kind of count the symptoms and administer medications kind of based on that. So then what happens after, right? So the patient is withdrawn, right? So now we're kind of talking about medications to kind of help when it comes to, there's a few different goals that we like to kind of look at. So ultimately the goal afterwards is to try to prevent and reduce withdrawal symptoms. So that's kind of what we were working on. And then after that, to try to prevent or reduce cravings, prevention of relapse, and kind of trying to restore the patients to their physiological functioning before they use the substance. And so this is, it's called MAT, so it's medication assisted treatment. Right now, there's about 3 medications that are approved, and I'll kind of go into them more later. But in general, when it comes to talking about why do we use medications to treat opioid use disorder, it's been shown to work. There's a lot of evidence to support it works, and not only does it prevent people from relapsing on using, street drugs or other types of opioids, but there's also a lot of different aspects that have been shown to improve with the use of medications. So mortality risk reduction almost 50%, which is incredibly high. Improved social functioning when they're on these medications. In general, there's decreased use of IV drug use, which can help kind of prevent the transmission of HIV, for example, or hepatitis and so on. So you kind of mitigate a lot of the risks that come from the general kind of lifestyle whenever you're involved with using opioids and so on. And in general, they tend to have a better quality of life. When it comes to length of treatment, there's really kind of no length of time that's recommended for these patients to be on these medications before they're discontinued. Most of the research that I've seen has basically shown that the longer they go on with the treatment, the less their likelihood of relapse or using street opioids. So they can be on these medications for quite a long time. And what happens when there's a tapering or a discontinuation, the relapse risk will tend to be like very, very high at that point. So in terms of FDA approved medications, the ones that I'm going to be talking about the most are methadone, the buprenorphine, and naltrexone. Naloxone, I didn't really go into it a lot, but it's what we know is Narcan, so it's what we use to, and it's kind of work as an antagonist. It can kind of prevent an opioid overdose. And this is kind of a general description of how these work on the receptors. Understanding that is kind of what's I find the most helpful to be able to kind of gather why we use one over the other, for example, and if you're ever needing to switch from one over the other, kind of understanding how they work and the mechanism of their action, I find makes it a lot easier. So when we talk about methadone specifically, we're talking about a full agonist. So heroin, for example, is a full agonist, so is methadone, but there's a lot of differences between the two that I'll kind of talk about in a little bit. And then the second one is buprenorphine, so that's a partial agonist. So you can kind of see here, it doesn't activate the receptor as much compared to a full agonist would. And then naltrexone is an antagonist. It basically blocks the effects of opioids, so that even if opioids are used, they're not able to bind to the receptor and create that euphoric effect. Okay, so talking about methadone specifically, so it's a full opioid receptor agonist, which, like I said, is similar to heroin, right? So, but why do we use this, right? Why is methadone been chosen kind of as that medication? It has a lot of differences when it comes to heroin, for example. So it could be taken PO. It has a much slower onset of action. It lasts for a lot longer in the body, and then it kind of offsets a lot slower than heroin. So instead of that high, fast up and down that's associated with substances of abuse, methadone kind of is a lot smoother when it comes to that, and lasts for quite a long time in the body. The kind of struggle with it is that it's very hard to find places that will give methadone, so not anybody can prescribe methadone. It needs to be administered by specific clinics that have been approved to be giving methadone. And then buprenorphine, so it's a partial agonist, and because of the partial agonism, basically, it kind of creates a ceiling effect where no matter how much buprenorphine you take, you still can't get that euphoric feeling, and you also can't kind of run into the issues that overdosing on opioids would cause, which is that respiratory depression and so on. So it kind of keeps that, which makes it a very safe medication in general. So that's kind of where that safety profile comes from. It's nature as a partial agonist, basically. It has a very high affinity to the receptors, and it's slow to dissociate, which are kind of important aspects of why it's a good medication. However, in order to start this, the patient needs to be in withdrawal before starting. So if they're taking like heroin, for example, and you give them a partial agonist, it will basically precipitate withdrawal, and that's not a good time for anybody. So they need to already be going through withdrawal before you're able to start this. It's not absorbed. It has very negligible PO absorption. So when we talk about how buprenorphine is absorbed, a lot of times it's either IV or sublingual, but most of the time whenever we're prescribing buprenorphine now, we're kind of talking about Suboxone specifically. So that's buprenorphine in combination with the naloxone, and there's a lot of different formulations of it. But most of the time it's administered sublingually because that's allows for the buprenorphine to be absorbed. So the reason that was done basically is to avoid, so you can see that buprenorphine is absorbed via IV or sublingual. So if you give buprenorphine alone, there's potential for abuse, that the patient can inject it and they can kind of get a similar feeling or close enough to what they're kind of seeking. So to try to prevent that, the naloxone was added because naloxone is not really absorbed via PO or buccal or sublingual. So if a patient is taking the Suboxone appropriately, the naloxone is not really doing anything. But if they inject the Suboxone and attempt to misuse it, the naloxone is absorbed and it basically counters the effects of the buprenorphine. So yeah, I think that's most commonly now. I think Suboxone is used. I can't really think of any reason why like mono buprenorphine would be preferred that I can think of.
Used to be for pregnancy and breastfeeding patients, but not anymore. And if a patient has any type of allergies, reaction to naloxone, then you might give just a Subotex, which is the buprenorphine monodrug. But most of the time we use this. Just an update on this absorption on buprenorphine, IV, sublingual, and we have sub-Q now, which you will talk about later. And the naloxone absorption only IV, and we have also intranasal. Just kind of update on those two.
So yeah, like I said, Suboxone, it's a combination of buprenorphine and naloxone, and it's a way to kind of prevent the misuse of the buprenorphine. And I don't know a lot of information about this, but I wanted to kind of include this because this is I think the most recently approved form of buprenorphine, that instead of having to take the medication every day or multiple times during the day, it's actually an injection that you can take once a month.
And this is actually sub-Q, not IM, so it's beautiful. We do a sub-Q once a month injection and slow release, like you mentioned here, and patients usually they love it. So it actually intervenes with behavioral addiction too. So the patients, they don't worry about, so they just come, they get the injection and they forget about it for 1 month. They don't have to deal with taking the medication sublingual once a day or 3 times a day. So it kind of helps with the behavioral piece of the addiction too. But not everyone is able to do that, unfortunately. Some of them, they still need that behavioral piece. They still feel the need to take the medication every day to feel that it's working. But most of my patients, 90% is doing really well.
Okay, and then I kind of wanted to show this real quick when it comes to talking about how buprenorphine might interact in combination with a full agonist. So in general, despite the fact that buprenorphine is a partial agonist, its affinity to the receptor is a lot higher than most common kind of like pure opioids that we talk about. So if a patient is on buprenorphine and they end up using heroin, it's not able to displace the buprenorphine, so you still don't get, again, that's the way it works to help kind of reduce that pathway of kind of activation and then reward and so on. And so they don't get the euphoric feeling even though they're using the opioid. And then the opposite is true. So if they are using a full agonist like heroin, because buprenorphine has a stronger affinity, you can actually displace the heroin from the receptors and replace it. And that's kind of the logic of why you wouldn't want to give somebody buprenorphine if they're currently using heroin and they're not in withdrawal, because that action of the buprenorphine coming in and replacing the heroin is what causes a precipitated withdrawal, which again, unpleasant. So, and I wasn't gonna go into this in a lot of detail, but this is kind of a sample, an example of what an induction might look like if you're starting somebody on Suboxone. So kind of, again, asking questions about when was the last time they used opioids, and then using the cow scale to see if they're in usually mild to moderate is kind of what we're looking for when it comes to whether they're ready to be given Suboxone or not. And you can kind of check in to see if you give them the Suboxone and then check in with them an hour later and they're having the precipitated withdrawal, you stop the Suboxone, of course, and then you try again the next day. And yeah, it's basically kind of a repetition of that same like question and answer of whether the patient is kind of in withdrawal, and if it's helping with the withdrawal at that point, you might be considering increasing the dose over time and so on.
We used to do that in the unit, if you remember. I used to do that, but unfortunately I'm not able to do that as much as I used to, even though we have patients coming in for opioid detox. And if you remember, if you noticed, almost 100% of them coming in with the use of fentanyl. So even if they are coming in with the use of, let's say, cocaine or methamphetamine, they all are mixed with fentanyl now. So the fentanyl, even though it has a very short-acting opioids, it acts like a long-acting substance, long-acting opioids, because the metabolite of the fentanyl stays in the system longer. So even though we say it's a short-acting opioids, because of the metabolites, you can find it up to even 20 plus days in the system. So because of that, we no longer can do this regular standard induction. Even in the outpatient, I cannot do it anymore. So either I have to give my patients a very, very small doses of buprenorphine, like 0.5 milligram once a day, and then build up gradually over the 5 to 7 days, or I need to give 24 milligram of buprenorphine, boom, in the first day, right away with first dose. So, and this is only after after 3-4 days of last use of fentanyl or any substance that mixed with the fentanyl. So unfortunately, it's not always possible in the inpatient unit. Mm-hmm. So patients, they don't stay 4 or 5 days in the unit, unfortunately. 2, they don't stay, again, 7-8 days for the small doses. So it's kind of becoming really, really tricky to start the patients in the unit with the buprenorphine medication. So that's why, if you notice, we keep doing regular standard clonidine detox more so than before, which is Suboxone is much easier in terms of the detox. You just give one medication, you're done. You don't have to give any other comfort meds. But unfortunately, because of the fentanyl, we cannot do it anymore. It's more complicated now.
So I already kind of talked through this about kind of switching between them. So switching from methadone to buprenorphine would precipitate withdrawal, but the opposite is not true. And then the last medication is naltrexone. So this is an opioid receptor antagonist. A lot of the times, it was previously approved for alcohol use disorder, but later on it also became approved for opioid use disorder as well. Again, because it's an antagonist, the patient needs to be opioid free for a certain period of time, depending on the kind of the half-life of whichever opioid they were using, because it can cause severe withdrawals if given while they're still having opioids in their system, basically. And you can do a Narcan challenge test, basically, to see if they're ready to be given naltrexone. And the good thing about naltrexone is that it can be prescribed by pretty much any provider. So I kind of went through them in like decreasing and increasing scales of like availability. So methadone, very specific clinics that can give it. Buprenorphine, I think now you only need to do like a certain number of hours courses to be able to prescribe Suboxone. And then naltrexone can be prescribed by almost like any provider.
Actually, it changed. Buprenorphine now can be prescribed by anyone.
Oh, really? Yeah. Okay.
Yes, you used to. Yes, you need to get that course you mentioned, but not anymore. I think this year they changed that. But as a physician or as a clinician, prescribing clinician, you need to get 8 hours of opioid CME training. Which is, just goes through your CME for the licensing. It's the same thing. So anyone who wants to prescribe the Suboxone can prescribe Suboxone now. So, which is great.
Yeah, because that's, increased
Did
availability.
you mention the increasing that numbers? So it's great.
Yeah. So, the naltrexone, compliance with it kind of varies. Again, kind of because of it's antagonism, basically. People can't really get that euphoric feeling or any kind of like relief from the naltrexone. And then I kind of just wanted to briefly touch about kind of barriers when it comes to treating opioid use disorder. So we kind of talked a little bit about the stigma initially that can sometimes prevent people from seeking help, and there's a lot of misconceptions kind of about the use of methadone and buprenorphine when it comes to treating opioid use disorder, kind of seeing it as, you're treating like opioids with opioids. It's the same thing. What's the difference? So there's a lot of kind of education that needs to be had, basically, to kind of educate the public in terms of what opioid use disorder is and the treatment and why it's used and so on. And regulations is another thing, which, regulations are there to keep people safe, of course, but changes like the one you just kind of mentioned have been like really important to increase the availability of access to care, because I think there's like a limited amount of methadone clinics, for example, but obviously they're trying to work on making them more available and so on. And I think that will continue to improve kind of as time goes on. I think that was it. Yeah.
Any questions? That was great.
Yeah.
Thank you guys for attending.
All right. No questions? No? We covered everything.